Welcome to my presentation on the feasibility of implementing trauma-informed approaches within psychosis services. This presentation will cover the link between trauma and psychosis, trauma-informed care and how it's implemented, barriers to implementation, and a few future recommendations based on current research and what we know so far. First, we'll be looking at the link between traumatic experiences during a person's life and the onset of psychosis after such experiences. Experiences of trauma, particularly during childhood, have consistently found to be linked to the onset of psychosis across studies. Experiences such as physical and sexual abuse, emotional abuse, neglect, and bullying, amongst others, are some examples of trauma. In cases where genetic predisposition to developing psychosis is strong, trauma has been found to trigger the onset of first episode psychosis and prodromal symptoms. From the figure on the slide, it's clear to see the strong association between various types of trauma and psychotic disorders such as schizophrenia. Within the UK, a study looking at service users within an early intervention service found that more than 61% of service users reported experiencing different kinds of trauma, particularly during their childhood. Studies have consistently found that both single event or acute trauma and multiple event or complex trauma can impact psychosis in the following ways. More severe psychotic symptoms compared to service user experiencing psychosis without prior trauma. Studies have found service users respond less well to interventions for psychosis if they have a history of trauma. In some cases, memories of traumatic events have been shown to manifest as persecutory beliefs or paranoia-inducing hallucinations in patients with psychosis. In addition to an increase in positive symptoms, trauma has also been found to be linked to an increase in negative symptoms, such as a lack of motivation, reduced willingness to engage in social relationships, for example. We can look at this in a bit more detail through a meta-analysis of 29 studies on a total of 4,680 participants. The studies consistently showed an increase in both delusions and hallucinations due to forms of trauma such as neglect and sexual abuse. However, despite strong relationships between trauma and positive symptoms, the meta-analysis didn't find the same for negative symptoms, except in the case of childhood neglect, where these symptoms were significantly present across 15 out of 29 studies. Now that we've looked at the link between trauma and psychosis and how these tend to co-occur, we begin to understand the importance of implementing trauma-informed care in psychosis services. In this section, we'll briefly look at SAMHSA guidelines for trauma-informed approaches, and we will be looking at how these can be implemented in clinical settings. Trauma-informed care is based on the understanding that most people in contact with mental health services have experienced trauma. This provides context to a person's presenting symptomatology and should be taken into account when treating and developing formulations for psychosis. For example, a person presenting with symptoms of persecutory hallucinations would be treated in the context of their previous trauma, perhaps of a terrifying encounter or a fearful figure in their childhood home. Contextualizing a person's illness through the lens of trauma helps mental health practitioners better understand how victimization and fear perpetuates their symptoms and affects their recovery. SAMHSA's framework essentially asks, what has happened to you rather than what is wrong with you? It places emphasis on services realizing the impact of trauma on a person's recovery and symptoms. It aims to recognize the signs of trauma in service users. In practice, this would look something like routine screening. Responding to service users' needs and presenting symptoms through a trauma-informed approach. This can look like trauma-informed CBT, where memory work is conducted and the symptoms of psychosis are appraised to trauma-aware lens. Most importantly, it seeks to actively resist re-traumatization. Take a second to do a short thought experiment with me. Imagine the experience of being sectioned or admitted to a hospital ward. This is an unfamiliar place with bright lights and strange new faces you've never seen before. Perhaps this might feel a bit overwhelming. Now imagine going through this when you're already coping with the experience of seeing or hearing things that are not there. It's clear to see how dealing with mental health services can be re-traumatizing if someone already has a past experience. So what would this ideally look like within a psychosis practice? We would aim for this to include patient-centered care, where collaborative dialogue between mental health practitioners and patients is encouraged. We would actively aim to prevent traumatization. We would screen for trauma routinely, and NICE guidelines for PTSD and psychosis would be followed. Auditing and training for staff would be conducted on a regular basis, and routine inquiry into the services treatments would also be conducted. However, this is an optimistic picture compared to real-world implementations of trauma-informed care. Psychosis services are often confronted with barriers such as a lack of funding and the ability to adequately train staff, limited time or resources to screen for trauma symptoms. Imagine services with large caseloads or waiting lists, for example. Or even after screening, the question arises as to how to properly carry out trauma-informed care. What would this look like for each patient's unique treatment formulation? This can be a tricky thing to tackle, especially as there's no set manualized approach. Other challenges include a potential lack of awareness around the prevalence of trauma, or these symptoms being overlooked, so primary symptoms of psychosis can be prioritized and treated first. To better understand the feasibility of implementing trauma-informed care within psychosis services, it's essential to look at how these are currently implemented across mental health services. Recommendations based on findings from mental health practitioners delivering care for psychosis found themes of adopting a top-down approach to implementing trauma-informed care to be more effective. This has been characterized across implementation science papers as recommendations for wider organizational change and a push towards employing trauma-informed care on a service level. This would mean applying the approach of treatment for all patients, regardless of presenting mental health complications. At the NHS level, the 10-year long-term plan rolled out in 2019 prioritizes training staff in conducting trauma-informed screening and approaches across all mental health services. Our next slide will look into this in more detail. As hospital admissions for psychosis can range anywhere from 60 days to over a year in more severe cases, the Standards for Acute Inpatient Services for Working-Age Adults Manual, released by the Royal College of Psychiatrists, might also be relevant to mention here. The manual outlines essential criteria for running inpatient services. It encourages the use of trauma-informed care and screening methodologies to recognize if a service user has experienced trauma of any kind. On a national level, in terms of equipping staff with training, there are many commitments already placed on NHS workers, particularly within mental health services where staffing and resources can be short. While the incidence and prevalence of psychosis as a mental illness is relatively lower compared to other severe mental health disorders such as bipolar disorder, the treatment formulations are often very resource-intensive and require input from a multidisciplinary team. This can usually include many social workers, psychiatrists, care workers, and more. Given the incidence rate of new service users being referred to early intervention services per year, a shortage in the delivery of training services for NHS staff becomes really apparent. Findings gathered from 59 multidisciplinary team staff through an online survey found that 20% or roughly 11 respondents found a barrier to implementing trauma-informed care was a lack of confidence in their skills. 86% or 50 respondents felt they had a lack of training, whereas around 47 respondents felt a lack of resources and insufficient support affected their ability to provide trauma-informed care in an effective way. I've chosen to illustrate this here in the form of pie charts. To better understand how feasible implementing trauma-informed care across psychosis services is, it's important to look at the barriers in a little more detail. I've compiled a table based on findings from Sweeney et al.'s paper on the barriers facing the implementation of trauma-informed care. First, we look at NHS-wide barriers that make implementation harder. For example, staff shortages, austerity, and underfunding. Second, we look at organizational cultures within services. A lack of supervision, training, and support can hinder the feasibility of implementing such care. And third, we will look at the problem posed by relying too heavily on biomedical models of mental distress, perhaps where there's little acknowledgement on the impact of social-cultural factors on trauma. Now that we've looked at barriers in detail, let's look at what we can be doing differently moving forward. Firstly, we'll be looking at steps to better improve how we implement trauma-informed care within mental health services. All these steps emphasize adopting a patient-centered approach that encourages active collaboration and engagement with service users. First is seeing symptoms through the context of trauma and its impact. Second, understand the intersectionality of trauma and how culture and social factors affect each person differently. Third is to create a culture where sensitive discussions of trauma can be facilitated, as trauma survivors are oftentimes reluctant to bring this up themselves. Fourth, provide support specific to their type of trauma. For example, female service users might want to be seen by a practitioner of the same gender if they have a history of sexual assault. Fifth, prevent re-traumatization in mental health services. Sixth, build a relationship of trust and transparency between practitioners and service users. Seventh, encourage collaboration and mutual input from both practitioner and service user. Eighth, empower service users to make informed choices about their care they receive and see them as experts on their recovery. Ninth, prioritize the safety of service users and implement safeguarding procedures to prevent re-traumatization. And lastly, facilitate mutual support between survivors of trauma. Vital to improving the implementation of trauma-informed care is understanding who needs it and in what capacity. The Trauma and Life Events, or TAIL checklist, is the first validated screening tool designed to routinely screen for signs of trauma within psychosis services. It was found that the checklist displayed high validity and sensitivity for picking up on traumatic events such as bullying, abuse, neglect, and childhood adversity. It is hoped that administering short yet effective screening questionnaires on a routine basis will help practitioners identify the presence of cumulative trauma and PTSD, and ideally prevent re-traumatization when someone is receiving care. In conclusion, traumatic experiences have been well documented as a significant risk factor for psychosis, particularly experiences of neglect, sexual or physical abuse, and emotional abuse. Trauma-informed care is based on the understanding that most people in contact with mental health services have experienced trauma. This understanding provides context to a person's presenting symptomatology and should be taken into account when treating and developing formulations for their psychosis. Barriers such as a lack of training, support, and access to resources hinder the implementation of trauma-informed care across psychosis services. Understaffed psychosis services, little feedback from service users, and a lack of awareness around the impact of trauma can be seen as markers of reduced feasibility. Recommendations for future improvement include active collaboration and engagement with service users to formulate support that takes their trauma into account and adopting a patient-centered approach. To improve feasibility of implementing trauma-informed care across psychosis services, it is essential to make use of routine screening for signs of trauma and PTSD. This can also provide practitioners with the awareness necessary to prevent re-traumatization and victimization while receiving treatment.